My name is David Salmon from Moffitt Cancer Center in Tampa, Florida. I'm the myeloid section head, so sort of overseeing all the clinical trials in the myeloid section group with focus on patients with myelodysplastic syndrome and acute myeloid leukemia. So today I really summarize the latest breaking advances in patients with leukemias, and I would say this encompassed myelodysplastic syndrome, acute myeloid leukemia, as well as acute lymphoblastic leukemia from the recent ASCO conference. So I think to start with, we're finally looking to have a new novel combination on top of an azacitidine backbone in patients with higher risk MDS. So I presented a very large cohort of nearly 95 patients that got azacitidine magrolimab, which is this first-in-class inhibitor of CD47 that basically unlocks the innate immune system, allowing for activation of phagocytosis. Response rates have been quite encouraging to date, and I think more impressively has been the survival data, which the survival was really not reached. Again, this is a cohort of 95 patients, and then really supports the ongoing pivotal trial, the ENHANCE-1 trial, which will read out the end of this year. I also presented work by my collaborator, Dr. Davar, on p53 AML data, which are similarly encouraging, although it's this most challenging group of patients, and supports another randomized phase 3 trial, the ENHANCE-2 trial. I then looked at the impact of measurable residual disease, and I think what's very clear is that MRD prior to transplant does matter. I think that's not necessarily surprising, but data presented by Dr. Horgan were intriguing that not all mutations are created equal. So if you were IDH1 or 2, that actually did not have relevance, whereas FLT3 and NPM1 were highly prognostically significant. I think moving the molecular targeted therapy approach forward, both with targeted agents as well as on top of intensive therapies as well as non-intensive therapies, is really where we're going. So there's a number of intriguing presentations. I think there will be a new frontline approval really from EHA of quizartinib in the frontline setting, but whether or not the sort of older midostaurin or newer inhibitors such as quizartinib, gilteritinib, crenolinib are better, I think is an open question. I think we're seeing intriguing MRD negativity rates. Whether or not we can get away from transplant in a subset of patients, I think is an important consideration, but lots of combinations are ongoing. I think this does bring a level of complexity. We know that the cytopenia toxicity, especially on HMA venetoclax backbones, is tough, but the response rates are good. So I think, again, what's the best way to treat these patients? You have a fit 65-year-old patient. Is intensive therapy, non-intensive therapy better? I think that's an open question. We looked at some other interesting combinations with intensive chemotherapy. I think lastly, as far as acute lymphoblastic leukemia, they're really making major strides with many new approvals. I think in the older patients, the question is getting more and more away from chemotherapy, especially if you're Philadelphia positive. Very intriguing data presented by Dr. Shore at MD Anderson, a ponatinib blinatumomab combination with over 90% of patients responding, over 80% of patients MRD negative, and actually 2-year event-free and overall survival of 93%. These are really great data, small subset, need to be validated in larger trials, but do argue that we may definitely be able to consider chemo-free approaches in the Philadelphia positive setting. Other combinations in the Philadelphia negative, such as with inotuzumab, blinatumomab on top of dose-reduced chemo, have also showed intriguing data. And lastly, we now have our recent CAR-T approval in the setting of acute lymphoblastic leukemia, not just our younger patients. This was based on the ZUMA-3 trial presented by Dr. Shah, one of my colleagues at Moffitt Cancer Center, really showing impressive complete remission rates of over 50%. And these rates are durable in patients that have failed many lines of therapy. Again, where's the best setting to utilize this therapy? Can we move it more up front? MRD settings, I think, are open discussions. So I think, really in conclusion, quite exciting data in the fields of myeloid leukemias and acute lymphoblastic leukemia, and really encouraging that major strides to ideally cure more of our patients are being made as we speak.